Good jobs.
All right, should we get started?
Let's do it.
Let's do it. Thank you guys for coming at 5 o'clock. I know it's happy hour somewhere, but not here just yet. So I'm Aaron Kraut. I'm the program director at the University of Wisconsin. This is Amer Aldeen. He's the CMO of US Acute Care Solutions and an education research collaborator of ours. So obviously we're going to talk about the job market. And this is something nobody's said a word about in the last couple of years, right? That's why you're here, because everybody has the utmost confidence you're going to get whatever job you want. So we're going to do a couple things with this talk. And first and foremost, I'll tell you that neither of us have any financial conflicts of interest. I will, since this is a small group and you've put your trust in us, Carrie, I will put my trust in you for a second and make a confession. So I feel like I'm a pretty academic guy. Like I've always been an academic EM. I like to talk about the literature and debate the finer points of patient care with folks and cite some studies. But it pains me to admit it. On occasion, I've talked about things where, maybe I've just read the abstract, or perhaps I've heard about studies on a podcast, and I haven't actually read the whole paper. So I'm sure none of you have engaged in that kind of nefarious behavior, right? Certainly not any of my residents. But this paper, which we'll talk about, the crux of the launching point for this discussion, the EM jobs report projections for 2030, I promise you I've read like 30 times. So I know that backward and forward. And in my role as a PD, I became acutely interested in this as I'm helping all these residents find jobs and fellowships, and it was really germane to our discussions, and people were really worried about this. So I was interested in diving into what exactly was going on. And obviously, I don't have all the answers, but today, in the next 20 minutes, we'll hopefully do a crash course in how to think about this EM workforce projection study in the context of everything that's happened since that report was published. We'll talk about just that, the changes in the EM landscape since this landmark piece of literature came out. And then I think, hopefully most interestingly, we're going to talk about what does this feel like and mean to people like all of you, stakeholders, people with boots on the ground, and a real stake in how this conversation goes and what happens with the job market. And we will present some preliminary data from our education research collaborative around what are people feeling and actually seeing with the jobs market, not just what does the paper say. Okay, so I promise I won't tell your bosses, colleagues, PDs, whatever. Raise your hand if you are familiar with this. Like you've heard about it, how many people have read it? Okay, cool. So a couple people, but most people haven't, and that's fine. You don't have to read it if you don't want to. It's pretty short, but I'll tell you everything you need to know. So first and foremost, I think it's important to acknowledge like really smart people. Some of my mentors, a lot of leaders at this meeting put their effort into creating this projection, and I want to say they had the best intentions, right? They were just trying to do a good job, and mathematical modeling is inherently challenging, but hindsight is 20/20, and me as a skeptic and someone who's a PD, I feel like there's a few big problems with both this report and the subsequent implications that everybody took from it that we should at least go through so you understand, it's not just taking my word for it, but you can see what we think the challenges with these numbers are. So what did they do? Basically, it's a mathematical model, and they generated a number of different inputs and put it into an equation and said, what do we think? Are there going to be jobs for people? Are we going to have too many people working in EM in 2030, so 10 years from when this came out? And the first thing you need to do is estimate how many EM providers, so physicians, allied health professionals, APPs, were working currently. So they took data from 2017 to 2018, that year. And one of the biggest problems initially with this model is that about a little more than 10% of the people they called practicing full-time emergency physicians for the purposes of this workforce study, they weren't actually taking care of people. They didn't bill CMS for patient visits in that year. Maybe some of those folks were, doing research and not practicing clinically. Maybe they were PDM docs, but 10% of people they said were current contributors to the workforce full-time. They weren't actually contributors to the workforce. So that's a faulty input. Second thing to know is, you can go to the next slide, Amer. They made this assumption that in that year that they collected all this data, they said everything was fine and dandy. It was a steady state, that the supply of docs was in balance with the demand. That, I don't have data to back this up, but I'm pretty confident when I say I'm not sure that the supply really equaled the demand. I mean, there were lots of places that are in desperate need of board-certified emergency physicians, and other places where there was a surplus of folks that want to do EM and they couldn't get jobs. And maybe in balance it was net neutral, but at least anecdotally there were definitely mismatches, at least geographically. So I'm not sure this assumption holds true either. So the other thing that they needed to do was they needed to figure out, okay, so how's this workforce going to change over time? They needed to know how many people are going to be entering the field of emergency medicine, and how many people are going to be leaving. So they could estimate how many people would be entering. They just looked at the average growth in the number of residency programs and the number of spots they had and said, all right, GME programs are going to grow by 2 or 3% per year. But they also had to look at attrition. So how many people are leaving the field of emergency medicine? Where are the job openings going to be from people retiring or otherwise leaving clinical medicine? And we'll talk about how they may have grossly underestimated that. But that went into this mathematical model. So I'll skip over this or just be really brief, but they also had to figure out how productive are EM docs going to be? Is AI going to change everything, and one emergency doctor in 2030 is going to be able to do the work of 3 EM docs in 2020? I don't know, but they had to make some assumptions around that. And they also had to make some assumptions around the demand for our services. So we have an aging population, right? I'm sure you're feeling this in all of your clinical practices, that people are just sicker, they're more complicated, they're living longer, and they utilize services more, so they had to factor that into the equation, that we might need more EM docs on balance just because the population in the US might need more emergency care. So bottom line, you all probably know this number. This workforce report said, geez, there's going to be 7,000 excess emergency clinicians in the year 2030, and this is really bad. Alarm bells went off everywhere. They assumed a relatively modest 2% growth in GME residency spots. Remember this 3% number, so they assumed 3% attrition. And then I think potentially accurately, they assumed that APPs were going to see 20% of ED patients, which is not that far off from what they see now. So workforce report has a bunch of limitations. And I'll say one more time, this is hard work to do, and I think the authors of this report deserve a lot of praise. It's impossible to get this right. But I think more worrisome than getting the model right are the implications that came from, what did this mean to stakeholders, to students potentially interested in EM, to current residents and fellows, to employers, to the entire GME enterprise. So just to review, they assumed that 11% of people were EM docs in 2017 and 2018 that were part of the workforce that actually were not. They made some assumptions around supply equaling demand. They estimated attrition in emergency medicine around pre-COVID data, and some things happened between 2019 and 2023. And then they also assumed that EM physician productivity wasn't going to change, and they didn't really factor in geographic maldistribution into this model. So where are we now? I don't know if you guys know Dr. Dark, but this encapsulates for me. I mean, I remember the feeling I had when COVID started. We were at Cord in New York in 2020, and it was just this weird, eerie sense of something is wrong. And I had that same sort of sentiment after the match this year of man, things are just not right. The world is turned topsy-turvy. And I'm not going to sit up here and suggest that this jobs report was the only factor that contributed to the match that we had, but I'm pretty confident it was one of them. And so I think for all of you, it's important to understand what the limitations of this were, not to take all of those conclusions at face value. But I think we should also examine what are some things that changed since then, and obviously COVID was one of them. You can go to the next slide, Dr. Aldeen. But attrition is a real thing that we know now with really good data they absolutely underestimated in this workforce projection. So Dr. Gettle talked this morning, hot off the press, brand new data that he presented. I don't know how many saw his oral abstract, but that's even more updated than this. So this study came out a few years ago, and they said actually 3% was a pretty big underestimate, and actually the attrition rate was more like 5%. We heard this morning it's actually more like 9%, which is a huge swing in terms of what implications it has for 2030 and who's actually going to be working and who doesn't. And we can debate the finer points of this, but this is a big deal. So we, of course, want to know, what does the job market look like now? And I can provide some anecdotal evidence. I just talked a little bit about attrition. In 2021, this is by no means really robust data, but one of the folks that does an industry publication, next slide, Amer, looked at roughly 30% of the EDs in the US. 2021 was kind of like, we're just starting to think about emerging from the fallout of the pandemic where no one was coming to the ED, everybody had to cut hours drastically. And it turned out that lots of people were hiring. Like the vast majority of people were like, yes, we need physicians to work. So we, as a group of academic educators, wanted a little bit more robust look at things. And we wanted to query folks that were boots on the ground, stakeholders like all of you, to say, what are you seeing, experiencing, feeling, and what's your perception of the job market, rather than letting this workforce projection just dictate how scared or not scared everyone should be about it. So I'm going to introduce Dr. Aldeen to tell you a little bit more about what we discovered.
Thank you, Dr. Kraut. Appreciate it. Thank you for attending so late. As Aaron mentioned, my name is Amer Aldeen. I had the privilege to work at Northwestern for the first 8 years of my career. That's where I did my residency, and that's where I got to work with Aaron, so it was awesome. We actually started this Emergency Medicine Education Research Alliance to look at questions like this, and we decided, after looking at the workforce report, how are we going to study this? What's the best way? So our group at USACS, we run 8 residency programs. The Emergency Medicine Education Research Alliance represents a number of us who are in education and folks like Aaron who are leading programs. So we got together and decided, hey, let's just survey and let's just figure out how are residents thinking about the workforce report and the job market in general. So we can go to the next slide there. So we decided to do a quick survey. It's a Likert scale, 8 questions, and our primary outcome was likelihood to obtain a desirable job right now. That was our primary outcome. We also asked questions about, all right, what's the market looking like in 10 years? How about getting any job in emergency medicine, and interest in pursuing different geographic areas. So we did this in October 2022, so this is just before a lot of this updated workforce data came out. Importantly, it was before the match came out. So, there's the caveat. So we had 830 responses, and that represented about a little less than half. And we queried emergency medicine residents at these programs, and we queried faculty, and we queried fellows. So this is a breakdown of respondents, roughly 45% of each attending and resident, and then a smaller cohort of fellow physicians. We'll do the next slide. And this gives you an idea on the left of the breakdown of respondents by residency program. So you can see it's 23 different residencies. So it's a big swath, actually generally concentrated in the Midwest, so there was that bias there. But then again, emergency medicine has probably more programs per capita in the Midwest than anywhere else. And then you had the PGY levels there. So these are the responses here. So the way to look at these graphs is basically blue and purple mean agree strongly or strongly support, and then the red and the yellow means disagree strongly or disagree or very low or low. So the likelihood to find any job right now, 90% of folks said, hey, we think it's pretty likely you're going to find a job. But as far as desirable job, only about half thought that. Now, this is all respondents. So this is attendings and residents. And attendings and residents were virtually equal when it came to the proportions of these different questions. Looking at the future job market, again, slightly less than half were confident at the 10-year mark. And then we asked about how familiar are you with a workforce report? Are you really familiar? Do you really understand it? Did you do the abstract thing that Aaron said he never does? Or did you actually read the paper from front to back. So we asked them about familiarity with the workforce report, say how great a factor might this have been. So we'll do the next slide there. So this we looked at. Now this is only the residents responding. So we saw that lots of urban interest, lots of suburban interest. And then again, although the rural interest is pretty low, it's like 25%, there was still some rural interest. Folks may be interested in going to rural medicine. I still think there's a huge deficit in rural emergency medicine interest. So that was an issue. And then we asked them about, hey, are you interested in doing a fellowship? And if so, do you think the fellowship will help you get a better job? Will it help you get any job? Will it help you get a desirable job? And you can see the proportions there. And actually most of, almost half, I guess, just about half, a little more, thought that the fellowship would help their chance of getting a desirable job. And remember, this is 380 respondents, resident respondents, pretty distributed throughout the country. And then the fellows were interesting. The fellows, we separated them out. We weren't sure in the end whether they should be cohorted with the residents or cohorted with the faculty. So we just thought, let's just keep them separate for now. And a far greater proportion of them felt that the fellowship was going to help them get a job that they wanted. There's obvious self-selection there, right? Like, I did the fellowship, but for sure this is going to help me. So, but it was still good to see. The rural interest is less. It's just how it is. I think we could make an argument that we should take, 10 urban residencies every year for the next 5 years and move them to rural areas, and we'll balance out this issue of workforce. It'll be the right thing to do for emergency medicine. So we'll do the next. So what we concluded generally based on this, and again, within the limits of the fact that this was a majority Midwest study, but still we had, West Coast, East Coast represented. Over 90% think that actually you can get a job in emergency medicine. It's not like you're not going to get a job, but only about half think you can get a desirable job at this stage. I wonder what that number's going to do now that the match has happened. I wonder if that's going to be less or more. I would guess it should be more because the match there's fewer emergency medicine residents going into it, or at least American-trained emergency medicine residents. And then about half are familiar with the workforce report, and then I've got the interest in geographic areas there. We'll do the next slide because that has the association. So we did logistic regression for these, and we calculated odds ratios, and we said, okay, what are some of the associations? There actually weren't that many associations, but what we did find were that fellows were less confident than either attendings or residents, which was interesting. I'm not sure if that was just statistical anomaly. Attendings with leadership positions were more confident, to the tune of an odds ratio of almost 3, about a desirable job and a future job outlook. So in other words, your faculty who are very experienced and have leadership positions think that this is okay. You're gonna get a job. It's fine. The most experienced people. And then this I thought was the most fascinating is attendings with a high familiarity with the workforce report. So the better they knew the workforce report, the more confident they were that people could get a job. Now, I don't know what that means. I don't know if that means that they knew that the workforce report had all these flaws in it, and therefore they're super familiar with those flaws, therefore they thought, it'll be fine, don't worry. Or does it mean that they just have greater perspective because they're, that they just know the market better and they know that this is not going to be an issue. We've seen this in other specialties. So hard for me to say why that happened, but I thought it was pretty interesting that the more they were familiar, the more they were confident. So, all right. So you heard from Dr. Kraut that the initial EM workforce report had assumptions that didn't actually pan out, that the attrition rate actually was not 3%. It was not even 5%. It probably is somewhere between 5 and 9%, closer to 9%. And so that big miscalculation or not quite accurate prediction is actually going to be the difference between a surplus, I think, and a deficit. And I actually think we're going to have a deficit. In my group alone, we have probably about 2,000 emergency physicians in our group in 30 states across the country. And we have significant vacancies where we can we need physicians to get jobs. And this is despite the fact that we employ over 1,000 PAs and NPs. So it's the presence of PAs and NPs, of APPs, is not, in our experience, in any way detracting from the demand for emergency physicians. Absolutely there's demand. And so for those of you who are looking for jobs or worried about it, I wouldn't worry so much, just anecdotally. I'm going to pass this to Aaron for the last word.
I can speak from up here. It's all right. So we're not in the prediction business, but I think I have a lot more questions than answers about the anecdotal evidence around a deficit of emergency physicians. As Dr. Aldeen mentioned, I think the long-term kind of specialty-specific implications for EM is a different question, but for everyone in this room, I have 100% confidence that you are going to find a really, really welcoming job market, and that's been my experience as a PD, where like never before have I seen groups that were highly competitive competing over residents to hire them, and that's in really competitive job markets. So that's never been the case. And I think the more you know about this stuff, to Amer's point earlier about folks that were really familiar with the workforce report, people are still confident that you're going to be able to get a good job, you're going to be able to get any job in EM. So if nothing else, as a PD, that's a message I want you to leave with. Certainly there are lots more questions about what do we do to address this problem in a multifaceted way for the good of our specialty in the future. But I think for you all as stakeholders, for me, for people like Amer, for residents, for fellows, for faculty in the room, I don't think this is quite the emergency for individuals that it was once sounded as. So we're finished right on time, I think. Wonderful. So happy to take any questions or engage in discussion. Hopefully there's some disagreement with some of this and we can talk about it.
And I'll repeat your question for the purposes of the recording. So yes, sir.
The study about resident familiarity with the workforce, has anybody looked at student familiarity with this? Because obviously the number of medical students, U.S. medical students going to the field has decreased. My sense, working with medical students, is most of them are not familiar with it. Maybe they've heard it from second or third-hand source. That, like you mentioned, there's probably other factors affecting why U.S. medical students are choosing other specialties. But that would be an interesting kind of follow-up to say, are medical students not taking the specialty because of potentially?
Yeah, that's great. I'm going to just summarize your question. The question was, we did the resident familiarity with the workforce report. Is there any data on student familiarity with the workforce report? Aaron, I'd love for you to comment as well. My experience has been that it's not the workforce report that has caused students to exit. And I say again students, this really is American allopathic students, to a lesser extent, American osteopathic students to exit the specialty or not enter it, because the international students have come in to fill the gap. I think it's the fact that ED boarding has been so bad, and deans maybe have seen the report. I know specifically of deans who have told their students, hey, you might not want to go into emergency medicine. I mean, that's the going kind of advice, which from my perspective, as an emergency medicine physician, I don't like that. I think we should get our students to go back into it. I join all of you. I told our group as well, anytime you can talk to a dean at your academic institutions, go and speak to him and say how awesome emergency medicine is. So, Aaron, I'm sorry.
I agree with all that. I think we made a conscious decision not to survey students as part of this research instrument, but I do think it's an interesting question. My assumption is you're exactly right that nobody, students are on subreddit forums and hearing this fourth, fifth hand, and it totally spreads like wildfire. And I don't have all the answers as far as the solution. I think advocacy is one of them, but us just building up our specialty in a positive light and highlighting the rewarding aspects of doing this job and maybe demystifying some of these things will go a long way.
Oh, Leon Edelman, how are you? Good to see you. How's it going?
So this question is actually for Dr. Kraut. So
Yeah, step aside on it.
That's all good. We talked enough.
You're really leading the way. So one comment that you made was that the PA nurse practitioner workforce likely won't be increasing by all that much, but in the workforce report it showed their trajectory to be like 6% increase year over year. What where does your confidence that that workforce isn't growing all that much come from?
Yeah, you're right. Maybe I misspoke a little bit. I do think I believe the workforce report projections in that respect because I don't have any data to suggest otherwise, right? Like logically it makes sense that I was just talking a few hours ago with a colleague from Iowa about their APP residency, and I think like it or not financially it makes sense for a lot of places, particularly in rural spots, but also to augment a workforce in more urban spots. Even with this, so if we believe the workforce projections for 2030, and APPs are going to be seeing 20% of patients, so 1 in 5, even with that, I think our gigantic attrition numbers far outweigh the impact of that. And I think it's also, this is more just my speculation, but it's a lot of states are, maybe you've seen it in the public press, are pushing back at the legislative level around like, gosh, patients deserve to see a board-certified emergency physician. Like there's some report in Tennessee, I don't know if you guys saw it, about a lady who had a miscarriage and she was seen a few times and like misdiagnosed. And I love our APP group. I think they're super capable, but I've heard a lot more about laws around like you must have physicians on site 24/7 to supervise. So I think there's always going to be a demand for our unique skill set and level of training.
We'll go here and then there.
Do you think that the COVID-19 pandemic accelerated the workforce attrition and that there may be some slowdown now that the end of the pandemic?
Yeah, so the question was, did the pandemic accelerate the attrition and are we coming back down from that?
What do you think in your group? I mean, you've got a lot of docs.
Yeah.
Do you believe in?
Yeah, 100% it accelerated the attrition, 100%. And partly that was early retirements too. So you had folks who were 58 to 60 who would have been working a couple more years. They're like, forget it, I'm done. Like, I don't need to do this anymore, and now it's become physically dangerous to my health. And then, certainly, and I think this is actually both a blessing and a curse of emergency medicine, is that and a great part of it, I think overall it's more blessing than curse, is that we are uniquely suited to do administrative positions of leadership at the hospital level, at the educational level, at the physician group level, and that's great, but that takes us out of clinical practice. I mean, Dr. Kraut doesn't practice as much as he did. I don't practice as much as I did in the ED, and that's a function of the fact that we have a broad skill set. So definitely think we have seen the pandemic accelerate attrition, no doubt. That attrition has slowed, but it's still higher baseline than it was pre-pandemic. Yes, sir, with the glasses.
I had 2 items. One, just a clarifying question. I assume that the term desirable job was left to the interpretation of the respondent.
Yes, the term desirable job was left to the interpretation of the respondent. Yes.
And the second is, and I'm not one to quote methodological flaws.
Please.
Study, but I noticed that the largest group of respondents were the faculty. And I guess the point of curiosity I had was like, how well are they positioned? I guess the assumption there is that these are faculty that are deeply involved in the hiring process, but how can you necessarily control for that?
Yeah.
You know what I'm saying? Like, how are they the best people to speak to this, given that
Yeah.
they may not be looking for a job?
Absolutely.
For 20 years.
Totally agree, and the question is, and I'm glad you're poking methodological flaws. These are all things we discuss, so that's why we're here. That's why this is SAEM, right? The question, a very intelligent question was, well, shoot, why should we listen to the faculty? They've been out 10, 15, 20 years, and they're not even looking for jobs. How can they know? You're absolutely right. We talked about this when designing the study. The 2 issues to that is, number 1, the resident responses were exactly the same as the faculty responses from a statistical standpoint. When we separated those groups out, they had the same confidence and the same desirability and all that stuff. Now, that may be because the faculty are the ones who are coaching the residents and teaching them on what the job market's like. Certainly that's part of it. So they were statistically similar. The second is that the faculty may have greater perspective having worked elsewhere at jobs, and we don't know this, but many of them may have worked elsewhere or be familiar with colleagues who are working elsewhere, whereas the residents probably only know that one particular site. So I think one could argue about whether or not the faculty really understand, and then you could further argue, to your point, that I think I'd said that the experienced faculty, the ones with leadership positions, were the ones who are most confident. Maybe they're falsely confident. Maybe they don't know. It's beyond the scope of our paper to answer that, but it's a great question. So.
I think to add, Amer, one of the really cool things about getting to partner with someone like Dr. Aldeen and do this research is, he has access to this gigantic group of, really important stakeholders in this jobs conversation, or people that aren't in the ivory towers of academic medicine. And, to get the perspective of, you probably have data on this, like members of your group. I'm sure once anybody joins USACS, they never leave, right? But, if you're working in non-academic
No, that's not true.
emergency medicine, you're statistically likely to look for other jobs, take other jobs. Like you would think, I would think these people have their finger on the pulse just as much, if not more so, as us in academics about like, what's it like out there? Maybe I want to move somewhere else, or I want to, explore different opportunities.
Yeah. Yes, sir, in the back. No, that's you, sorry, in the middle.
Is there any plan to do a study for medical students? Because I think it's probably very multifactorial, and we don't know the answer of why they're not choosing, but now after the math is 554 spots on the field, they have the choice. Those that are residents and fellows and faculty, we don't have the choice to change specialties. So at this point, I think it does help us in the future and looking forward and being positive, but focusing on those that have a choice and to go into our specialty to continue to gain competitive applicants, I think would be far helpful to compare.
Yeah, so another call for a student study. So yeah,
I'm at an institution at UT. I don't think they're going to listen to me as if I might be biased as I'm telling a student, is generally where they can look at data as a medical student and say, hey, this is, or we can interpret their data and approach it from that perspective versus one-on-one. I think it's helpful, but I think they also need to be heard exactly why they're not choosing our specialty.
Yeah, good points. All good points. I think that is the next step, is to do a student study. So for sure. Yes, ma'am.
This may be slightly tangential, but was it Dr. Geller's presentation this morning about attrition? I noticed that there was actually a really big jump before the pandemic hit. The last data.
Yeah, 2019.
The 2019 data point showed that it had gone from like 3 or 4% up to 7 or 9%. And from your perspective as somebody who can sort of see a large group, did you see that in your group, and how does your group at least, or how does the general population understand that from a pre-pandemic standpoint?
Yeah, so the great question. The question was in Dr. Cameron Gettle's talk. I'm repeating the question for the purpose of the recording, that he had found that there was actually a jump in attrition before the pandemic even hit in 2019. And did we observe that in our largely community-based group? The answer is no, we didn't observe that. We did not see a jump in attrition. We did not see early retirements. We did not see increased turnover. Part of it is that when folks leave our group, we don't know if they've left emergency medicine altogether or they just left for a different group. We don't get great data on that. But we didn't see any sort of turnover that was big. We certainly saw the attrition during the pandemic, that first year, 2020.
This is pure speculation, but I'm curious if people agree or not. I think that part of it is just changing priorities in our culture. But people, even in my academic world, like folks are like, you know what, I'm just going to do 75% time or 50% time. Like I want to, go do some leadership thing, or I want to spend more time with my family. And my guess, what I'd like to ask Cameron if he was here, and I'm going to follow up with him, is I bet you have data looking at, not only how many ICD-10 codes are billed, but what's the denominator of people billing those codes. And my guess is the future emergency docs in 2030, like nobody's gonna work like 17, 12-hour shifts a month anymore. Like that's just not, but some of these old docs, like that's what they did for 25 years. And I just don't think, patients are sicker, it's more complex, like there's more demands on the departments, it's busier, there's more boarding. So I just don't think that's sustainable. And so I think even more reason to be optimistic about there will be work for people because no one wants to put in 70 hours a week for 30 years anymore.
And actually, a point to that is we used to think we were being really progressive because our minimum hours for benefits in the community world was 108 per month. And we thought, oh, this is great. This is, it's going to be lower than other folks. We're going to give people time. And 108 is a lot now to a lot of people. And that's in the community. I mean, in academic world, it's different. But in the community, 108 is actually not that much. And yet, there's a new normal. That one of the leaders I went to at Christiana, she actually laid it all on the table. I went to the CMO conference and she said, we just got to accept this. People aren't going to work as much. That's just how it is. And everybody just deal with it. And when that happens, it's exactly what Aaron says. The number of people who are working lots of hours declines, tons of spots available, job market, great. This is the best time to go into emergency medicine from the student perspective. Yes, sir.
Aaron, you made almost, not exactly, but close to the point that I was going to make, which is that when I came out 20 years ago, people were working, like you said, 160, 170. Some of the partners are working closer to 200 hours a month. Nobody wants to do that anymore. Like, it's a generational thing, whatever it is. But that's one of my biggest criticisms of the workforce study. You were very gracious earlier, talking about, I've been much less gracious. I've got a lot of anger. I kind of saw, I think it was a major factor in the recent match. I think it's going to get worse before it gets better. I'm really angry about that. It hurts me about that. But is it your understanding, like, I'm not positive that I'm right about this, but my understanding is that what we've just been talking about, that one of the reasons we need more doctors is because the doctors have working fewer hours. So we need more doctors to staff the same number of shifts and needs. That was, my understanding is there's no accounting for that in the workforce study. It was one of about a dozen major flaws in the interpretation. Am I right in saying that there was no accounting for that in that study?
Yeah.
Repeat the question, Aaron. So.
Yes. So tell me if I understood this right. Your question is basically, did the workforce study account for the number of hours worked by the EM physician?
We need more docs because the docs we have are working less.
Yeah, no, to my knowledge, it did not, and that's one of the things I'm most interested in figuring out. As I mentioned before, I bet Dr. Gettle has this data, and we could just look at, how many independent practitioners of EM that are billing for those, however many millions of visits a year, and I bet it's a whole lot more than it was, 20 years ago for a comparable number of visits. Per capita, what does Amer or what do I bill in a given year compared to what does a doc work in 160 hours, 180 hours a month bill? I think it's going to be much lower. But I bet we could get that data and publish it.
I must say I share your anger with the workforce report. I was like, this is going to go down as the most poorly timed study of all, whether it's methodologically flawed, but my goodness, why do we release this now? My entire life is spent now, for the last year, 2 or 3, trying to get folks to come work and come join, and well-trained, residency-trained emergency physicians, board-certified, to come work in our EDs for community medicine patients who need the care and need the training of excellent ER docs.
So I think we're about at time. You guys we can keep talking. I don't have to go anywhere, but feel free to leave if you need to go, have a cocktail or something.
Question?
With this trend in, what's considered full-time for an ER doc,
Yeah.
fewer hours, do you see salaries trending with that?
That's a great question. So the question was, with the trend of lower hours, what about salaries? So what we have observed is that definitely if they're working lower hours, the salary is going to go down, not because the hourly rate's going down, just the total number of hours going down. However, in some markets, the hourly rates are going up. Those are usually the rural or less urban markets where the hourly rates are going up. I'm not quite sure whether it's commensurate for the number of hours desired down, but certainly they are going up. There was tons of movement into the locums industry that we saw during the pandemic, and the locums industry, by definition, has very high hourly rates, but lower total hours. So there's a balance there. I think I think that the hourly rate for emergency medicines will continue to climb slowly, but maybe not commensurate. And actually, even more interesting than the hourly rates and the number of hours worked is people seem fine with that. They seem fine with working much less, maybe getting paid moderately less, and they're just like, all right, this is it, the new normal.
So I heard we gotta give up the room, but we can keep talking. Yeah.
All right.
A lot of interest in this topic.
Yeah.
Yeah, we'll make ourselves available for